Hi, I'm Dr. Joe Suker with the Arizona Trauma Association, and this is Trauma in a Flash. Placement of a chest tube for pneumothorax or hemothorax is a very common procedure in trauma and critical care. Despite the daunting appearance of the procedure, it requires very little in the way of tools. Shown here is a very basic setup for placement of a chest tube. 1% plain lidocaine is used for skin anesthesia and for intercostal nerve block injections. An 11-blade scalpel, scissors, a long peon, a needle driver with zero silk, and of course, a chest tube. I want to point out the tapered or pointed end of the chest tube. It is configured in this way for open chest operations where the surgeon can pull the chest tube from inside the chest cavity through the chest wall to the outside. This end should be cut off so that it can be more securely attached to the Pleurovac tubing connector. The chest tube should be loaded on the peon as shown. While the surgeon continues to prepare, an assistant can prepare the Pleurovac. The foot of the unit should be placed in its open position. Sterile water is then placed into the marked port. This port is in different locations for different units, so pay attention to the instructions on the particular Pleurovac that you have. On this unit, the sterile water is located on the back. Suction can be attached at this time. The patient's skin should be widely prepped with chlorhexidine, draped in full sterile fashion, and a timeout performed. The site of entry should be at the 4th or 5th intercostal space in the mid to anterior axillary line. This is identified using the nipple or the inframammary crease as external anatomic landmarks. Lidocaine is infiltrated in the skin, subcutaneous tissues, and below each rib for at least 3 ribs surrounding the insertion site. Additionally, IV sedation and analgesia should be administered for optimal patient comfort. I use an 11-blade scalpel to create an incision in the skin approximately 2 centimeters below the rib space that I intend to enter. In this way, I create a small subcutaneous flap to decrease the risk of leak around the chest tube. A large Kelly or peon clamp can be used to dissect down to the chest wall. I use scissors for soft tissue dissection as it tends to be a more efficient tool for creating a path through the soft tissues as seen in this video. Next, a peon clamp is guided through the soft tissue defect and placed just over the rib. Using your dominant hand, stabilized by your non-dominant hand, the peon is pushed through the intercostal muscles and parietal pleura into the pleural space. The clamp is spread, creating the defect between the ribs, and removed. The chest tube is then inserted into the pleural space, guiding the tube superior for patients with pneumothoraces and posterior for those patients with hemothoraces. The chest tube can be secured with a large silk or nylon suture, and the side is dressed with split gauze and tape. It is then connected to the Pleurovac tubing. I secure this connection with 1/4-inch silk tape in a double helical pattern. When done in this fashion, it allows for easy visibility of the connection so that it can be quickly checked for any disconnection. Additionally, it is the strongest way that I have to maintain a secure connection. Finally, a post-procedure chest x-ray must be performed. This chest x-ray shows the chest tube to be in good position. Note that the sentinel port of the chest tube to be well within the thoracic cavity. Thank you for watching this week's episode of Trauma in a Flash.